Vanakkam. Examining a child with a birth brachial plexus palsy is quite challenging. You cannot test the voluntary movements, you cannot test the muscles, and you cannot test the sensation. But what you can do is an astute clinical examination. Just a clinical examination will reveal a lot of data about what has gone wrong. This is more important because other investigations that can normally be done for adult brachial plexus palsy may not be applicable in these infants who have had a birth brachial plexus palsy. But all patients with birth brachial plexus palsy may not be presented to us during infancy itself. They may present a little later during early childhood, around 3 to 4 years of age. The clinical examination is different in such children. More number of tests can be done, but of course, the treatment is going to be totally different. This video is going to deal with the clinical examination and assessment of infants and children with birth brachial plexus palsy. This is the second video of our series on understanding B2P2, birth brachial plexus palsy. We shall cover the topic of clinical examination and assessment in birth brachial plexus palsy under the headings of clinical examination in infants, classification systems, the clinical classification, anatomical classification, and the physiological classification, understanding the prognosis and sequelae of birth brachial plexus palsy, and finally, clinical examination in children. We will first deal with these topics in this video. Clinical examination is done in infants with two purposes: to determine the extent of injury and hence arrive at a prognosis, and also to plan the treatment protocol. And it is important to note that before a clinical examination, a thorough knowledge of anatomy of the brachial plexus is important, and this has already been discussed in a previous video which can be accessed by clicking the icon above. A good knowledge about muscle actions and joint movements is also very important. The child may be presented to us as soon as it is born, but we need to wait for 2 to 4 weeks after birth so that the edema subsides and the clinical picture becomes more apparent. A sequential clinical examination every month is important to see the progress of development. This will help not only in understanding the basic problem but also in decision making regarding the treatment. When the problem is presented to us in early childhood, the parameters of clinical examination are different. The clinical examination of infants with birth brachial plexus palsy will have to be done in a programmed way. First, a history has to be elicited, the posture must be considered, movements examined, reflexes elicited, clavicle and humerus must be examined, chest movements must be examined, the eyes must be examined, and finally the sensation must be checked. A very detailed history must be obtained. The maternal history with history of diabetes during the pregnancy, the obstetric history to learn about the method of delivery and the use of assisted labor, and finally the postnatal history, the movements noted of the limbs, and whether the child is able to feed comfortably. In supine position, the posture is examined. In a C5-6 root level lesion, the shoulder is typically internally rotated, adducted, elbow extended, forearm pronated, and the wrist either in neutral position or kept in extreme flexion when the C7 root is also involved. This is the typical waiter's tip position. When all the roots are involved, typically the upper limb lies in a flail position by the side of the torso. When checking the movements, there are two types of movements to be checked: the passive movements and the active movements. The passive range of motion of all the joints should be assessed, but generally contractures and joint subluxations do not develop for several months after birth in birth brachial plexus palsy. But early limitations of passive range of motion may indicate other musculoskeletal abnormalities that may be associated. Though it is not possible to get voluntary contractions of muscles from an infant, we can evaluate the dynamic movement of the infant's shoulder, elbow, and hand by different methods. One is the natural movements that are occurring. The second is by a test known as the tickling test or the towel test. To encourage more movements from the involved limb, the infant can be placed in the lateral decubitus position with the normal side down. This way, the movements of the affected limb can be assessed. Tickling the infant may also encourage movements in the affected limb. Sometimes, throwing a very thin towel over the face of the infant may stimulate movements in the limbs, and these movements can be assessed. Just noting the movements may not be enough. The power of these movements also has to be assessed. This can be done by the regularly used MRC grading or the Gilbert-Tassin system. The Medical Research Council system may be quite adequate for adults, but for infants, it is a little difficult to perform. The Gilbert-Tassin system is simpler, but it is not quite adequate to assess all the muscles of the upper limb in the affected infant. In the year 2002, Curtis and Clark came up with the Active Movement Scale, the AMS, from the Hospital for Sick Children. This assesses movements with gravity eliminated and classifies it into 5 different grades, and then against gravity where 2 grades are assessed: less than 50% motion or more than 50% motion. And all these gradings are done for a total of 16 important movements in the upper limb. They need to be done sequentially whenever the infant is brought for a review. This way, the progress of movements or the progress of power can be documented. When there are decreased active movements of the affected arm, we need to test 2 important reflexes: the grasp reflex and the Moro reflex. A light touch of the palm of the neonate will produce flexion of the fingers. This is the grasp reflex and it disappears by 3 to 4 months. The Moro reflex was first described by Ernst Moro in 1918. It is present in full-term infants and begins to disappear by 12 weeks with complete disappearance by 6 months. This reflex is elicited by pulling up on the infant's arms while in the supine position and letting go of the arms, causing the sensation of falling. The normal Moro reflex reaction would be: first, there would be an abduction of the upper extremities, extension of the arms and fingers, followed immediately by adduction of the arms and the hands coming closer to the front of the body before returning to the infant's side. The absence of these reflexes on one side of the body may indicate brachial plexus injury, peripheral nerve injury, or a fracture of the clavicle or humerus. If it is a brachial plexus injury and it is an Erb's palsy, the upper motor neurons are involved, and characteristically the lack of the Moro reflex can be seen. If the lower motor neurons are affected, there will typically be lack of the Moro reflex and the grasp reflexes. Examination of the clavicle and humerus are important in a child suspected of having a birth brachial plexus palsy. In a particular study of 11,636 neonates, the incidence of clavicular fracture was 2.03% and the incidence of Erb's palsy was around 0.44%. The two conditions could also coexist, and if they coexist, an ipsilateral clavicle fracture is usually a good prognostic sign due to traction force divergence because most of the force has been taken away by the fracture. And a contralateral clavicle fracture is usually a bad prognostic sign as this indicates a high energy traction force. These findings are still not validated. The humerus is second only to the clavicle as the most commonly fractured bone associated with birth trauma. These associated fractures can result in a condition called pseudoparalysis, which could be caused by compression of the brachial plexus by the fractured bone, swelling around the plexus, or involuntary splinting of the arm in pain. This resolves more rapidly than a true obstetric lesion of the plexus.
The chest movements must be noted in a child with a birth brachial plexus palsy. When there is phrenic nerve involvement, there could be asymmetric expansion of the chest cavity and difficulty with oxygenation or feeding. The clinical finding of decreased chest movement may be obvious only in a thin-built child, but a chest radiograph during expiration, chest fluoroscopy or ultrasound during breathing can confirm the diagnosis. This chest X-ray shows an elevation of the right side of the hemidiaphragm, confirming phrenic nerve palsy on the right side. The eyes must be examined to look for Horner's syndrome, which is characterized by meiosis or constriction of the pupil on the affected side, ptosis, anhidrosis, and enophthalmos, as obvious on the left side of this example. It is usually associated with avulsion of the lower roots of the brachial plexus. But we can see Horner's syndrome without a lower root injury also. And conversely, we can see lower root involvement without Horner's syndrome. Sometimes this Horner's syndrome may gradually become less, and this indicates a good prognosis. Eliciting sensory loss may be difficult in an infant, but history of biting or chewing some part of the upper limb may indicate a loss of sensation in that part. The Naraka's sensory grading system is a very practical and simple system to record the amount of sensation present in the upper limb of the infant. Apart from all this routine clinical examination, we also need to determine whether the level of the injury is preganglionic or postganglionic. Postganglionic injury may be manifest in three important findings: Horner's syndrome, elevated hemidiaphragm, or winging of the scapula, which is due to the paralysis of the long thoracic nerve supplying the serratus anterior. The possible differential diagnosis has already been discussed in a previous video, which can be accessed by clicking on the icon above. After the clinical examination, we need to classify the findings and come to a reasonable diagnosis about the level of involvement. There are three important classification systems: the clinical classification, the anatomical classification, and the physiological classification. The most used clinical classification scheme was proposed by Gilbert and Tassin in 1984 and refined by Narakas in 1986. This classification system is used between 2 to 4 weeks after birth, when the neuropraxic lesions would be recovering, and this system permits definition of the extent of injury and may also guide the prognosis. The Naraka's Group 1 injury refers to an upper plexus injury or Erb's palsy involving C5 and 6 roots only. Here there is paresis of the deltoid and biceps with normal extension of the wrist, fingers and thumb. Clinically, we will find that the shoulder is adducted, internally rotated, with a pronated forearm and extended elbow or waiter's tip position. There is spontaneous recovery in 80% of these cases. In this Naraka's Group 1 brachial plexus lesion, because of the C5 and C6 roots involvement, the axillary nerve deficiency leads to paralysis of the deltoid and teres minor. The suprascapular nerve involvement leads to paralysis of the supraspinatus and infraspinatus. The musculocutaneous nerve involvement leads to paralysis of the biceps and brachialis muscles, and involvement of some parts of the radial nerve leads to weakness of the brachioradialis and supinator muscles. Naraka's Group 2 lesion is very similar to the Naraka's Group 1, except that here there is an additional involvement of the C7 root. Hence it is sometimes known as an extended upper plexus injury or extended Erb's palsy. Paresis of the deltoid and biceps, triceps and wrist extensors is present, but the flexors and intrinsic muscles of the hand are unaffected. The clinical features are the same as Group 1, but the wrist is acutely flexed because there is no extension possible. Spontaneous recovery is possible in 60% of these cases only. So in addition to the involvement of the C5 and C6 roots, the C7 deficiency adds on to a problem in the radial nerve, leading to paresis of the triceps, extensors of the wrist, fingers and thumb, and also the latissimus dorsi and teres major.
In Naraka's group 3, there is a total palsy with no Horner syndrome and involvement of the C5, 6, 7, 8 and T1 roots. The upper limb is completely flaccid and spontaneous recovery of the shoulder and elbow may occur in 30 to 50% of the cases. Naraka's group 4 is the same as group 3 except that there is presence of Horner syndrome and may be associated diaphragmatic palsy. This group has the worst prognosis because without surgery, severe deficits and defects of the limb can be expected. The anatomical classification is based on the roots that are involved. There are 4 categories: the upper palsy, the intermediate palsy, the lower palsy, and the total palsy. The upper brachial plexus palsy refers to involvement of the C5, C6 and sometimes C7 roots. It was described by Wilhelm Heinrich Erb in 1874, but in 1872, Guillaume Benjamin Armand Duchesne described 4 cases of complete paralysis involving loss of shoulder control and elbow flexion. The stereotyped waiter's tip posture with the arm adducted, shoulder internally rotated, wrist flexed and fingers extended is seen in upper palsy. The intermediate brachial plexus palsy was described by Frederick Joly in 1896 and further elaborated by Thomas in 1905. It involves C7, C8 and T1 roots and clinically presents with abduction of the arms, flexion of elbows and flaccid fingers and hands. With time, however, the muscles supplied by the C8 and T1 spontaneously recover to some extent, but not those supplied by C7. A majority of these cases were bilateral and thought to be related to an obscure obstetric practice, but most cases of bilateral birth brachial plexus palsy are associated with breech presentation. The lower plexus palsy was described by Augusta Klumpke and her husband Joseph Jules Dejerin. This type of palsy is rare. There is involvement of the C8 and T1 roots only, so the clinical presentation would be a flaccid hand in an otherwise active upper limb. The final anatomical category is the total palsy. It is essentially the condition as described for Naraka's grades 3 and 4, and it is a devastating condition with total loss of function of the arm. The 2 classification systems we have seen so far, the clinical classification system and the anatomical classification system, are based on the roots that are involved of the brachial plexus. But we also need to know to what extent the roots have been involved, and for that we need to see the physiological classification system. This too consists of 4 categories, that is, 4 possible ways in which the roots of the brachial plexus can be involved in birth brachial plexus palsy: neuropraxia, axonotmesis, neurotmesis, and avulsion. If this is the spinal cord, we have the roots coming from them. They are covered by a sleeve known as the neural sheath. If this sheath alone is involved, it is called neuropraxia and recovery typically occurs within 6 weeks. If there is an involvement of part of the nerve alone without involving the sheath, it is known as axonotmesis. Recovery may occur within 6 to 9 months. If the entire nerve along with the sheath has been divided or ruptured, it is known as neurotmesis and recovery will typically be incomplete. If the nerve root along with the sheath has been avulsed from the spinal cord, it is known as avulsion and usually there is no recovery. We have seen the clinical features and the examination of the infant presenting with birth brachial plexus palsy. But we also need to understand the prognosis. Will it recover? How much will the recovery be? And when will it recover? We need to understand the prognosis of birth brachial plexus palsy based on various studies by various authors. 90% of patients with group 1 B2P2 progressed to full spontaneous recovery if there were clinical signs of recovery before 2 months of age. Approximately 65% of patients with group 2 palsy recovered fully, but the remainder had persisting defects in the shoulder and elbow movements. It was also noted that the timing of recovery of this group patients was delayed, with clinical signs of recovery not evident until 3 to 6 months of age. For group 3 patients, less than 50% recover fully, spontaneously. The majority of these patients are disabled by significant deficits of movement throughout the arm. And in about 25% of these patients, even the wrist and finger extension was compromised. Patients with group 4 B2P2 have little chance, if any, for a full spontaneous recovery. The usual finding is a complete neurologic deficit of motor and sensory function in the affected arm. A study done in 1973, the collaborative perinatal study, reported that 93% of patients who went on to full spontaneous recovery had done so by 4 months of age. Furthermore, Metaza in 1984 reported that patients who showed no signs of clinical improvement by 3 months did not recover function adequately, and those who continued not to show improvement by 6 months had essentially no chance of adequate functional recovery. In this video, we have seen the clinical examination of birth brachial plexus palsy in infants, the different classification systems, the clinical, anatomical and physiological classifications, and we have also made an attempt to understand the prognosis of this condition. What we need to understand further are the different sequelae that can develop in birth brachial plexus palsy and how to do a clinical examination in children. These will be dealt with in the next video. I hope you enjoyed the video. I enjoyed making it. Please do click on the shown links to see more on the introduction to birth brachial plexus palsy and the video about the etiology of birth brachial plexus palsy. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.